webinar is frontline provider-led optimization of the pediatric and adolescent HIV viral load monitoring process. And we have our guest speaker for the day is Dr. Cyrus Mugo. Dr. Cyrus Mugo is the Senior Research Scientist at Kenyatta National Hospital, Department of Medical Research. And he has been doing research for over the last 10 years that is focused primarily on the HIV care cascade for children and adolescents. This included the introduction of the innovative pediatric index case testing that in Kenya has greatly helped close the testing gap for children. And this was between the years 2013 and 2017. He's also done a lot of work on studies on early start of treatment for infants, neurodevelopment for children living with HIV, as well as HIV self-testing by adolescents and youth in the communities. He's also done training of providers to offer adolescent-friendly HIV services and has been part of the team's leading development of tools for HIV status disclosure and transition from adolescent to adult care. He is the principal investigator for the PIMA study, which is a collaborative study with the County of Nairobi's Department of Health that looks at ways to optimize viral load monitoring for children and adolescents in care. So I want to welcome Dr. Cyrus Mugo, who will take us through our presentation for today. Karibu sana, Dr. Mugo. Welcome.
Thank you. Thank you so much, Dr. Ngono. I'm going to go ahead and share my presentation. I'm not very sure which view everyone is having. If you could confirm whether we're having the presenter view or the correct view using two screens.
Dr. Please put it on presentation mode.
Oh, okay. Okay.
Yeah, thank you. That's good.
Great. Thank you so much for the kind introduction. I'll spend about 30 minutes taking the group through the work that we've so far covered in the PIMA study. This was a study funded by the International Association of Providers of AIDS Care, who also have come up with this group. We call them fast track cities. In fact, I first had this first from Nairobi when I realized that Nairobi was one of the fast track cities. And you know, just to note that the Nairobi County is one of the fast track cities. So this organization was providing some implementation science funding, and we did some collaboration with the University of Washington, Kenyatta National Hospital, and the County of Nairobi. And those are my fellow investigators at the top left. So as a background, is just to note that Kenya is one of the East and Southern African countries with a high HIV prevalence and incidence in the world. And this is where 75% of all children basically reside. Anyone below the age of 24 who lives with HIV. And we do know that children and adolescents have high rates of viral non-suppression. While we are closing the gap on testing and closing the gap on putting them on care, they're still lagging behind adults. And even in viral suppression, they're also lagging behind adults. This varies though. In Kenya, we've seen that there is quite a big variation of between 35 and 43%, depending on what facilities you sample and the regions you're in, especially the low prevalence regions. Those tend to have the higher viral non-suppression rates. And one thing that has been noted in previous research is that clinics with shorter turnaround times for viral load tests have higher viral suppression rates. So this process does have some impact on the overall goal of viral suppression. So when you look at viral load monitoring as a process, first of all, defining the importance of the viral load information. It's key in determining the treatment success or failure. Since 2016, we no longer now talk about the CD4 count, and we are mostly looking at the virological outcomes as the key outcomes, that determine our determination. That determines whether someone is failing care and they need some interventions. And also to note that treatment changes can only be made with the viral load information as per the guidelines right now. So the Ministry of Health in 2016 adopted the WHO guidelines and also updated them in 2018, where we now have children and adolescents getting these viral load tests every 6 months. There is a change of definitions. While in the 2016 guidelines, we had people who are suppressed, that is, they have a viral load less than 1,000 copies per mil, and those who are unsuppressed. There is this differentiation of categories of those who are suppressed. There is the undetectable viral load, which is defined as less than 50 copies per mil when we are using the reference labs. Of course, when you're using point of care, undetectable is around 400 copies per mil. And then there's the low viremia, which is now the point between an undetectable viral load and viral non-suppression, which is 1,000. And for those who are undetectable, there is a guideline that the guidance that enhanced adherence counseling is done. So we've done some we've taken a good look at some of the data, national data, and in trying to understand what are the gaps in the viral load monitoring cascade. And I'm going to describe the cascade in a little more detail in the next slide. But what we found, this was in 2019, is that only 8% of those who were unsuppressed, they've had a viral load test, they have greater than 1,000 copies per mil. The guidelines require that there is a repeat viral load, but only 8% had gotten that repeat viral load within 3 months of getting the result. And even if you're to think about being a little more generous, less than a third had actually gotten this repeat viral load within 6 months. And for us, this was one of the key indicators that the process needs some retuning and optimization. And also to note that when finally those who got a repeat viral load got it, we had a big proportion, 42% were unsuppressed in that second viral load. So we had a confirmation of failure, of treatment failure, but only a third of those who had a confirmation of treatment failure had any documented changes on their ART regimen, which means that they've continued with a failing regimen to the point of when we got them in the study. The median time from the first viral load to the second viral load was, a median of 6 months, which is a long time. And so this requires some optimization. So when we talk about the cascade, basically, this is our study objective. We looked at how we were looking at how we could address gaps in this viral load monitoring cascade for children and adolescents, and we chose the Nairobi City County as the place, as a fast track city. It was a priority city, and we are hoping that the lessons that we learn here can be cascaded to other places. So we could divide the cascade into 3. That is the clinic portion that is pre-laboratory, and then there's a laboratory portion, and then there's the clinic portion again, which is post-laboratory. So a pre-lab clinic, laboratory, and post-lab clinic. And in the pre-lab, we basically are talking about the requests for the viral load, and laboratory is the processes of sample collection, sample processing, return of the result to the clinic. And then you come back to the clinic where we talk about return of the result to the client and then taking action on that result. So for our specific study, we had 3 aims, and one was to describe the viral load monitoring cascade, give a description of it. Then, identify failures in the viral load cascade and the relative contribution. And so this is important, the relative contribution of the different steps in the process. So how much does skipping one or failing to perform one item impact basically an adolescent or a child getting a viral load done? And then the last aim is to determine appropriate indicators for the process. We have an indicator, the biological indicator, which is the viral load, the measure itself. But we also need to start thinking about how can we measure success in the process? And that is something that will come at the end of the presentation. So we conducted this in Nairobi County Health Facilities, now under NMS. Just to note that Nairobi has an HIV prevalence of about 6%, and about 33,000 children and adolescents living with HIV are being served in about 220 clinics. But only about 65 to 70 of them are public. The rest are private, faith-based or swaps. So we selected sites. There were 38 public. So we were interested in the public facilities. So there were 38 facilities that had at least 100 children and adolescents in care. And, we wanted, to determine, since we were just going to select a few of the facilities, to sample a few of the facilities, we came up with indicators that we would use to select. And we wanted to go for high performing and low performing clinics. It was not a perfect process, but these 2 indicators were the ones that we thought would tell us who are doing well and who are not doing very well. And that was the proportion of children and adolescents with an up-to-date viral load as per the 2018 guidelines. That is, they have a viral load that is less or equal to 6 months old. And then the proportion of those who've had an up-to-date viral load who are virally suppressed. So we were aiming for 10 facilities, and but there were challenges because of COVID. This study has been conducted through the COVID period. We ended up with 1 high-performing clinic, and the score this was Langata, and the score was 50. The maximum score I think you could get was 100. Langata scored 50. We had also selected Kibera Amref, but who also scored very high. But we were not able to do site entry because of changes in the implementing partners. Then there were 4 who were not easy to classify as low performing or high performing due to a lot of clustering. That's Bahati, Umoja, Kasarani, and Kangemi. Then there were 3 low-performing clinics with these 2 indicators: Kasarani, Lunga, Karen, and Silanga. Silanga also had the same issues with change of implementing partner. So we ended up with 8 facilities. So this at the end of the day proved to be a very imperfect. Actually, when we get to the site, it's a very imperfect selection, and we actually came to realize that what we were calling high-performing was neither here nor there. And so moving forward, we realized that we don't make any reference to high-performing or low-performing clinics. This was a lot in vain, but it helped us at least get sites. So what kind of sites did we have? So out of the 8 sites, 7 of them reported having a pediatric clinic day. So they either have a pediatric clinic, so a separate room where children are seen, or a separate day that the children come to clinic. And this is important for when you're thinking about quality improvement. Also, all the 8 clinics had either an adolescent clinic or an adolescent day. Then thinking about children, that is 0 to 9, 5 of them had monthly refill and clinic schedule. So every month, children would be brought to the clinic. The other 3 had a varied schedule, which was anything between more than a month to 3 months. And then for the youth, adolescents and youth, 5 of the clinics had 3 monthly refill and clinic schedules. 3 had either 1 monthly, 2 monthly, and 1 clinic actually had more than 3 months clinic and refill schedules. 5 of the facilities had an electronic medical records register available. And this was important for us. Who are the people who are working in these clinics? 4 of the facilities actually had psychologists. 7 have community health workers or social workers, so they have this community aspect covered. All of them reported using the 2018 treatment guidelines. They were very familiar with the guidelines. All of them said that they, for children and adolescents, they have 6 monthly viral load schedules, and 6 out of the 8 reported, as per the guidelines, that they were following the guidelines on extended adherence counseling, which is required for anyone who is not undetectable, who does not have a viral load that is less than 1,000, less than 50. So we did a survey with the facility managers and asked them what they felt were the gaps in the viral load cascade. And this is in an effort to triangulate what gaps exist basically in the facilities. And this is what they reported: delays. So 4 main issues. One is delays in sample collection. That is a missed viral load appointment. And many of the reasons pointed out were school or caregiver commitments, social issues, especially pointing to children in single-parent homes. And this is an important social demographic issue, or children in children's homes. So you probably won't get someone to bring the children because you're the breadwinner and you're the only person who can bring them in. And then transport challenges by patients. And to put into context, this was also during COVID, and so this could have been could have weighed more because it was the COVID period, the transport challenges that we were experiencing at that time. Other issues were a lack of laboratory commodities, and this became a very big issue over the last 1 year. No dedicated lab processes for viral load testing, and very long turnaround time to get results, and therefore people actually lose track on who is supposed to get a viral load. We asked them whether they were ready to change the process and improve it. And this is not a perfect way of presenting readiness for change results, but some interesting things. Many of them said, our facilities, staff are very invested in changing the process. They are very committed in implementing changes. Staff can keep track of the implementing changes progress. But there were a few things that specifically they felt that they were not really ready to do. For example, staff, they said only 4 of the 8 facility managers felt that their staff could manage the politics of implementing changes. And this is an important aspect that I think moving forward, we can try and empower ourselves a little more. Also, staff, saying that they will do whatever it takes to implement changes. I think this sounds quite, people just being real. And then staff being confident in handling implementation challenges, and staff being motivated to implement changes. So all these are issues that they felt that even when we are going in and asking our frontline providers to lead the change process, that we have to keep this in mind. So we chose an interesting method to go through the process of identifying what problems are and gaps are in the viral load monitoring process, and then prioritizing them. We used what we call the failure mode and effect analysis method, which has 6 steps. First, you need to define your topic. And for this, we already had a topic, which is improve viral load monitoring. You need to assemble a team in each one of the units. We had 8 units, 8 facilities, so we assembled teams. And I'm going to show you how our teams looked like in the next slide. And then the next portion was developing process maps, going in and outlining all the processes and sub-processes. The other step is now conducting a risk analysis, identify the failures. So in each one of the sub-processes, what are the failures? estimate severity and impact of each failure, probability of occurrence, and detection of each failure if it occurs. Then the next step is develop an action plan. So get solutions to each one of the problems you've identified, starting with the priority problems, the ones that you've rated highest. Develop an action plan and implement that plan. And then the last step is the follow-up, where you can, monitor changes, sustain changes, share lessons, learn with others, which is what we're doing. And you can also repeat the failure mode and effect analysis process again. So this is how our teams look like. In general, we, the peer counselors and mentor mothers were the most, well, if you could use the word most important. I think this is true. They were among the most important people in the viral load monitoring process. And this is not an assumption that we had actually made before we got into the sites. And what was interesting was that this was also not, the teams in the facilities had not fully realized the impact the peer mentors, counselors, and mentor mothers had on this process. And this was a good realization because we now know whom to target. In the teams, we also had clinical officers, we had the nurses, we had adherence counselors, or what we call the patient supporters. We had the data clerks, another group that we came to realize that are very, very crucial in this process. And of course, the laboratory technologists. When we talked to the teams, 85% of them, there were about 60 in each of the sites. So each one of the sites had about 10 participants, 8 to 10 participants in the groups, as they were familiar with the treatment guidelines. And so we started our process mapping. What we can see in these pictures is the teams in different facilities going through the process mapping, discussions. And I think this is the same format we used, round tables. This was done during COVID. You can see the good masks. And Margaret, there in the red dress, she's leading the process, getting ideas from everybody so that we have good maps for each one of the facilities. So what we did is develop a map for each one of the facilities. We went to Moja, Dandora, Kasarani, Bahati, Lungalunga, Nangata, Karen, and Kangemi. And then basically looked at each one of the maps and made decisions. What is familiar, what is similar in each one of the facilities, and then what is different. And as we moved through the last few months, we actually realized that the process was very similar across the facilities, and only 2 areas did we find, I could actually enlarge this, did we find major differences in the facilities. So there were 4 facilities that had what we call the viral load order form, and there were 4 facilities that did not have this form, and instead used either paper, just wrote on papers, or wrote an appointment on the appointment card for the viral load monitoring. So how the map basically looks is that you start, an adolescent comes to the clinic, then there's a decision to make. So what we are seeing in the little prism there is a decision box. Is this a routine? Is this a viral load visit? Is a routine viral load due? And if it's a clinic day when a viral load is due, then the clinician will make the requests, and that is where they will do it either on the viral load order form or write it on the appointment card or a little white paper. And then the patient proceeds to the lab for the sample collection. The lab tech, this is another area where we found there were differences. In fact, clear demarcations. There were 4 facilities, the same ones who were using the viral load order form, who could log in their patient details remotely into the reference labs system. That is what we're calling LIMS. That is the system in the lab. And 4 facilities could not. And so those details were actually entered at the laboratory level. This is important again because for the facilities that can do a remote logging, they actually make the difference in how the patient details are entered. And if you've actually looked at the viral load data, you'll realize that that's a big, big issue. on how, for example, IDs for the patients are entered. So 4 facilities had the power to change that. 4 facilities did not. The next item is that the samples are shipped by a rider, and the samples are accompanied by a viral load requisition form. Some facilities also had what they called a manifest. Then we have the samples being processed, and the results are posted in the national, the dashboard. And we come back to the clinic. The laboratory technologists downloads and prints the results. So there are some facilities that had help, where the lab tech also had some help from the data clerks. And the data clerks downloaded the results and ensured that they were entered into the patient EMRs. So a decision is made on whether the results for the patient are either suppressed or unsuppressed. For all the 8 facilities, the priority was always getting those who are above 1,000 copies. And those are flagged, and they're immediately handed over to the clinician or to the patient supporters to start adherence counseling. And the TPA, that is the patient, the adherence counselor, will start the enhanced adherence sessions. Usually there would be 3. If they're not satisfied with the adherence, then they could extend it further. If good adherence is achieved, then a repeat viral load is requested. And if we still have an unsuppressed viral load, which above 1,000, then they would reconvene. The facilities convened what they called a multidisciplinary team. Again, the team basically that was doing this FMEA process, having the clinicians, lab people, data people, and so on. And they would make a decision on regimen changes, moving from first line to second line. Only one facility had experience with adolescents on moving from second line to third line. And for this, they had help from the county team. So this is how the map for the Nairobi County, basically, we can generalize and say it looks like for the viral load monitoring process. Next was identifying the failures. And we did this rigorous process over several visits, identifying what now you'd call the failure modes, the problems in the process, and looking at each one of the sub-steps. So looking at the viral load request, we came up, each facility had their own number of steps that they had. Some had 10, others 15, but we were able to condense them across the 8 sites into 9 specific steps: viral load requests, viral load sample collection, viral load tracking forms and remote logging, shipping viral load samples to the central lab, checking, downloading, printing viral load results, transcribing the results to the EMR or to the patient charts. There's the rebleeding in case of missing results. Then there's the enhanced adherence counseling, and then decision-making for those who require regimen changes. So as you can see, there were challenges in all those. And one that I would really want to point out is the viral load tracking forms and remote logging, where a lot of people identify that wrong IDs entered can actually be a big problem in the facility. And a wrong ID sometimes is not necessarily a big issue. It's just a question of entering a truncated ID. So the patient unique ID is 3250, and that is what you enter. The problem is that you don't enter the facility code, which would now fully identify that patient. And so it becomes very difficult to actually identify who that is. The next item was now barrier prioritization, which is basically rating of failures. You look at all the failures that you have, and for each one of them, you rate them in terms of severity. I'm going to describe what that is. Then the next thing is probability of occurrence. And then the last item is probability of detection. So let's start with what we have on the screen, which is severity of effect. And that is basically saying, if this problem occurs, what are the chances that this child or adolescent will eventually not get their viral load this time round? So when you score, and this is it should be, is designed to actually be very, very subjective. This is the general consensus. It's a consensus. It's one of those things we call nominal techniques. It's a consensus around the room. Everyone understands how they're scoring from 1 to 10. What 10 means? 10 means that this person will definitely not get this viral load. 1 means that there would be it's a slight annoyance. It's a question of that someone won't feel nice that they got a slight delay. Number 2, if the delay in getting the viral load is just for a few hours. 3 to 4, talk about low to moderate delays, just a few days. 5 to 6, there will be a delay in getting the viral load, but eventually within a few weeks, the person comes in. Then significant delays, a few months. Significant delays, 8 to 9, would be thinking about you have to wait for the next clinic, which could be 3-4 months later for them to get the viral load. Then thinking about probability of occurrence, the same logic. If you get this problem, what are the chances that, so with occurrences, what are the chances that you would experience this problem every time a patient requires a viral load? Or thinking about cumulatively, what are the odds of, that you will forget to do something or a problem will occur when a person requires a viral load? And number 10 is definite probability. This always occurs with at least maybe one person or many people when we require the viral loads to be done. For number 1, you're talking of people in the team saying, I have heard of this problem occurring, but I have not experienced it. Talking about a 5 or a 6 score would be moderate or high occurrence. Maybe 2 or so members have experienced in the last few months, or if you want counts, you could say in the last half year, we've experienced it a few times. So this is basically the way you get consensus on how to score on occurrence. In other literature, you'll find this just being called the frequency rather than probability of occurrence. Then lastly, detection rating. And this one, the score is reversed. Here we are talking about, in case a problem occurs, what are the chances that you will actually notice, or it will be noticed that it has occurred? And 1 would be, it's this certain, you're certain that if this occurs, we will always catch it in good time and get this person to go for their viral load. Versus number 10, where there's no chance that the error will be detected. And this person will go through their cycle of 6 months without their viral load having been done. Going to the middle, 5 or 6, it's a moderate chance that the error will be detected. And maybe you're talking about it will be detected in the next visit when they come and something is done about that. So you take the severity rating, your occurrence rating, your detection rating, and come up with what we call the risk priority number. And this is what now we use to prioritize and say, this is what we want to go for as our priority. This is the problem that is the most injurious to our clients getting their viral loads. So that is what we go for. So examples of rating of failures, I'm just showing about 4 facilities. What is colored pink is the top failure for that facility. Umoja said that their biggest failure was in entering wrong IDs. Wrong IDs are fatal, basically, in Umoja. That's what they're telling us. If a wrong ID is entered, very good chance that this viral load will not be done. That's why they scored the severity scale at 10. Detection, they scored it at 8 because they're saying very low chance that we will notice that we've actually entered a wrong ID. So we don't have a mechanism to determine that we've actually done entered a wrong information, and so we need some correction. Going to Kasarani, for example, for them, again, it's entering a wrong ID. But going to Bahati, their biggest issue was viral load sample collection. Patients actually missing to honor the visit to the lab, either due to long waiting hours in the lab or just leaving when they're done with their clinic and refill visits. And as you can see, the scores are very different. And we are not really trying to compare the scores between facilities. It's within the facility, because you need to score everything for you to determine that That is, so it's not really comparative that the 400 is greater than the 70. They actually carry the same weight within each of the facilities. So what were the overall top failures that we identified? Clients living with request forms due to long waiting hours at the lab was one. Wrong incomplete IDs was the second, especially for those who are transfer-ins. Unavailability of clients for rebleeding. So if the lab says that the sample was not enough, or there was an issue with the sample, actually getting the client to rebleed is a big issue in facilities. Then delay in convening the multidisciplinary team in case you have a person who requires a decision to be made about their regimen or repeat viral loads. So those were the 4 top failures that were identified across. We also identified solutions for the top 5 problems in each one of the facilities. And thinking about, for example, Umoja, thinking about the viral load, talking about, Umoja, just moving back, the biggest issue was, the wrong IDs. I just moved back to the slide. The solution that they had for that was counter-check the 10. So they basically did an audit. They did an audit of, how they enter their IDs to check that every patient has the 10 full digits, their unique number, and also the facility number. And then sensitization, or the CCC staff ensure that they have a 10-digit code in all their required documents. And the person who was mandated with supervising this was actually the peer educator, in ensuring that everyone who writes any document at all concerning a patient, they've got to use the full ID for that. So what we did next is now institute, try and test some of these solutions. And we used the Plan, Do, Study, Act, what we call the PDSA cycles, borrowed from the continuous quality improvement measures. With the plan, what do you do when you're planning? Each team identifies the priority gap. This is the gap that is on top of our list. This is the one that we start with. Then identify priority changes to make. So we have many solutions to this one problem, but which one do we want to start with? Then formulate a plan to test the change, and then identify the indicator to assess that change. And this is important because you need to know that the change you are making is actually making a difference to the patient's lives. So identify an indicator to assess that change. Then the next thing is implement the change. That is a do. So you say we are going to, the next thing we are going to do is study. So we are going to implement and then study it. Analyze the impact this change is having in service delivery. And usually 2 weeks are good enough. Sometimes you can do less. You can do even 1 week, you can do just a few days to determine whether that change is worth instituting as something that you use in the clinic on a regular basis. And then you act. Now you act to either adopt the change and you say that this is part of our routine service, or you that's adopt. So, or you adapt the change, you make some changes to the change, and then you test it again. Or you can decide that this change is just more work without much benefit, so you abandon it. But there were big challenges that we faced. Many facilities were actually not doing viral loads. So you can't institute changes in the viral load process if you're actually not doing the viral loads. So you won't have a chance of a practical changes. What you have here is a picture of some of our patients actually going out and saying outside the ministry, we really need our viral loads to be done. We know we've had this crisis it went for quite a while. But we had 4 clinics that started doing these viral loads beginning this year. And for example, Langata, in their first session, they decided to tackle, what problem did they decide? So they decided to tackle clients missing viral load sample collection on the due date. Our healthcare workers had observed that the patients failed to go to the lab after they've had their clinic and refill visits. And the solution they were interested in is pharmacy refill can only be done after the lab visit. This is what they went to test. Specifics, the clinician indicates on the prescription that the patient was due for a viral load, so that the farm tech will know that this person, you're not just going to issue a viral refill without establishing that they got their viral load done. And the lab tech would sign that prescription to show that the sample collection was done. And here we had the peer educator monitoring the changes by auditing these prescriptions. They would sit at the end of the day in the pharmacy and ensure that what had been agreed upon, everyone who was required to have a viral load actually got it. And the team decided after 2 weeks of testing this change that this will be part of their routine for everyone who is due a viral load. Another example is Karen. Here they were talking about the big problem being different IDs used in different documents. Healthcare workers had observed that incomplete documentation of IDs in the lab order form, that is the first form by the clinician, that is a request form. When it has a truncated ID, this was cascaded to every other document and even the results. So the solution was that the clinician is required to write the full ID. And then, of course, the documents that follow, whether it's from the lab and so on, would do the same. The lab tech was to monitor this change, check all forms, and return to clinician any incomplete form. And they had no implementation challenges, and they thought that this was a good idea to cascade to, moving on. They had adopted it. And we had, other interesting things. So I'm not going to talk about Dandora, but they also had a beautiful change there that they implemented, and Umoja too. The other 4 facilities, unfortunately, by February had not started doing regular viral load monitoring. So what are the activities after this change process? One is we will be assessing healthcare worker satisfaction and competency in conducting and continuing with this failure mode effect analysis process. They've already given us feedback that they really like the process, but we'll want to do something more formal. And basically talking about their competency in the change process. We've collected some, data, qualitative data that we will use also to triangulate with the quantitative data on what barriers and facilities we have in monitoring our children and adolescents viral load. And this will be presented at a later date. Then lastly, we are planning for a stakeholders workshop. And here we are we'll be looking at, having looked at all this process, what are the indicators for the viral load monitoring that we would be interested in seeing and moving forward, whether it's in guidelines or, in our policies. And we are going to present our results to this stakeholders workshop. This will be, people in the city, in management in the city, and also people in the national government. We'll invite people from other counties too, because we would really want to get something that can be cascaded to other counties. We'll discuss the strategies that we want for monitoring at city level. So at facility level, what indicators do you want for monitoring your process? At city level or county level, what indicator do you want for monitoring the viral monitoring process? And then at national level. And we are hoping that this will align, we are going to basically align with the Kenya HIV Quality Improvement Framework, which provides for this quality improvement work. Thank you very much. I really want to thank our teams in the 8 facilities. They've done such a splendid job, and we continue to work with them. We will now move to prepare them, the facilities to take up this work by themselves. And also invite teams in other counties to also see whether they can borrow this process. And we are moving this work, this FMEA work into monitoring, into mental health, into implementing of mental health screening and management in our HIV clinics, and basically in several other areas to see whether we can generate some frontline provider improvements. Happy to take questions. Thank you, Carol.
Thank you very much, Dr. Mugo. for the very clear and precise presentation. We are now moving into the questions and answer sessions, and I want to invite our participants to ask questions. But I think just looking at the Q&A session, there is a question that asks, can we please get the link of the failure mode and effects analysis, the FMEA reference, which was on the previous slide. Again, there's a question on how the topic appears on the PPB portal. So those are two questions, Dr. Mugo. Maybe you can answer. And then the third question is, I would like to have a better understanding on who is a carrier and how is their status established. So you can start with those, Daktari, as we wait for other questions. Please raise your hand if you have a question, or you can just put it on the Q&A portal.
Okay, thank you very much, Carol. So the person who's asked about who is a carrier and how their status is established, I'm not very sure. I would really want to hear this question if they can be unmuted, and then Ruth Mburu, so that they can, I can, get to understand the context. Also, the team at the department can tell us about the PPP portal, so that we can get that there. I don't know if there's anyone who can answer that for us.
Team at the PPP portal, anybody to answer that, whether that is possible?
Yes. Thanks, Doc. For the CPD points, you'll be able to get them. For the medical doctors, I usually send them around 2 weeks from the time of the session. For the pharmacist, we'll follow up with the coordinators, but you should be able to get your CPD points. Sometimes there's a delay in getting the names. Usually put them down and give the register to the coordinators for them to combine. So you'll be able to get your CPD points. And also for the nursing, you get within 2 days. There's a slide that will show that. And for the clinical officers to keep registering. And once integrated, you'll be able to get all the prior CPD points. Thank you so much. For your question, keep them coming. Post them at the Q&A section. Thank you.
Thank you very much.
Maybe you can also, oh, sorry. Please proceed, sorry, please proceed.
Oh, thanks, Carol. I was just saying Ruth had sent a very good question, but I did not get the context. If she could be unmuted and ask, or maybe type the question once more. I unfortunately not get the context of the question. It was about a carrier, not very sure about the carrier. I'm also going to get this link posted on the Q&A so that you can get the FMEA right away, the FMEA link.
Yeah, so I think as we wait for Ruth to be unmuted, Ruth Mboro, kindly Agnes, if you can unmute her, we can answer these other questions. There's a question from James. He says, many thanks for this presentation. I hope you'll consider other counties. In particular, he highlights Nyanza, where there's a high HIV infection rate and a lot of HIV programs. There's also a question from Silas Maingi, who's asking you, Dr. Mugo, to explain about couple discordance, what it is. We also have a question from Mombasa. Dr. Yosa asks, when you were detailing the participants, there were no doctors in the list that you gave. So was this something that was planned? Again, maybe Dr. you can start with those and then we'll continue.
Yes. Thank you so much. Yeah, these are very interesting. So yes, in the stakeholders workshop, we'll definitely consider Nyanza region. We will definitely have representatives from there. Yeah, so we will get all the high burden counties to include in that stakeholders. Explain about couple discordance. If we are talking specifically about having a couple, one is living with HIV and another is not living with HIV. I think that's how I understand couple discordance. I hope that is good enough answer for you, Silas. Raise your hand, please, if that is not good enough. And yes, we do not have any doctors participating, and this is very true. I think many facilities many county facilities at the level that we were in will either not have a doctor, or the doctor will not be seeing clients in the HIV clinic. There's one clinic actually which actually did not also have a clinician, and the nurse, especially in the PMTCT, was the one who was doing both the work for the clinician and also the nursing work, what you'd call the nursing work. So there's a lot of task sharing and task shifting in the HIV program. So yes, was this by plan? No, it was not, but that is what we found.
Okay, thank you, Dr. Ari, for those answers. I think we can move on to the next set of questions. And James is asking that he feels the viral suppression threshold of VL less than 1,000 copies is very lenient, and he's asking NASCOP to consider lowering these thresholds because more developed countries are already doing this. I think this is just a statement, and I believe we have participants from NASCOP on the call. I think this is just a statement and observation from James. There's a question from Catherine, Dr. Mugo, asking, can I be safe when I engage in sex without a condom with somebody with LDL, an LDL client? Again, we have a question from Vincent Kioi. He asks, for the intervention in Langata, is there a risk that adding a requirement that the lab tech signs the prescription could act as a barrier to collection or refills by patients at the facility? Very interesting question. We also have a question asking, do we have HIV carriers? Looks like a follow-up to the other question. So perhaps we can answer those three, Dr. Ari.
Sure, yeah, thanks so much. So the threshold, that is very nice. So already the guidelines, the 2018 guidelines, provide for the lower threshold. So there are decisions that are now being made at the undetectable level, which is the less than 50. And that is starting enhanced adherence counseling. That is also recommended for what we are calling low viremic patients. That is those who are 50 to 1,000. But the treatment changes are the ones that have remained at 1,000. So also the repeat viral load is also actually, the guidelines actually recommend a repeat viral load for those who have persisting low viremia. Where the 1,000 threshold comes in is with the treatment changes. And I think that covers that. Yes, please.
Hello. Hello.
Hello,
Yes,
Ruth. Ruth, we can hear you.
Okay. I've been having a client who complains of one partner being positive and the other one being a carrier. The client was complaining of one being a carrier. The reason behind this client complaining of this person being a carrier is because there has been said there are people who are carriers and they don't show their status. When we use the strips that we do use to do the determination, they show that they are negative. But according to history, this client, who is a female, says that the husband had wives who have been passing on, and the current client, who is now the current wife, is positive, yet the husband is negative. So I don't know how true the claim is, but I would like to understand who is that said to be a carrier. That's all I would like to know.
Okay,
Yeah.
thanks, Ruth.
Yeah.
Dr. Ari,
So,
kindly,
yes, please.
kindly.
Yes, please.
In regards to my question about discordance,
Yeah.
Yes, please.
my question was about discordance is how would I explain to a client if it happens that it's a discordance couple, they're not on PrEP, but and they've been not using any the dual protection, a condom either, and they've been married for a couple of years, and either of the partner is not getting positive. So how do I explain the reasons behind one of the partner is not positive? Thank you.
Yeah, thanks so much. I'll try answer those ones very, very quickly. So I've not heard of the concept of an HIV carrier. So that's not a concept I've actually seen. You know, we have very, very good tests, whether we are talking about the antibody, antigen, or the viral tests. And you would know if a person is positive or negative in that sense. Now, we do have a few people who have been recorded in the world who started their ART during the acute phase. They were detected to have HIV very, very early on before they formed antibodies and were put on good ART. And so the antibody tests may not be positive, but the viral tests may be positive. They may show that they have they are living with HIV. And I think these are very few in literature. The question about discordance. So, having a sexual partner who is positive, that is not linear. That the probability of infection is actually not very, very high. I know these words are not the right words to use, but it's not linear that having a partner who is positive, you definitely get the infection. If you actually look at the probabilities per sexual act of getting or acquiring HIV from a positive partner, it's actually quite low. It's below 1%. Other factors that come in include what is the viral load of this person? Are they on treatment and so on? And that actually comes to the question that James Okech asked with the, not James, but someone asked about transmission of HIV for people who are and have undetectable viral load. And that is what the studies show, that a person who has an undetectable viral load cannot transmit the virus. So in terms of HIV prevention, you unequivocally, the studies are unequivocal, you cannot transmit the virus at an undetectable level. And the studies have actually shown it's anything below 400 copies per mil. So the intervention in Langata, a risk of adding a requirement is very, very true. In fact, that was one of the biggest cautions that we took up with the lab, that's one of the things that they have to monitor, settlements by the patients, and also whether they are actually getting now issues in the pharmacy itself. And in the 2 weeks that followed, those are some of the things that they were really keen on, and they did not find that they were getting a problem with patients in the pharmacy, either that acting as a barrier for a refill or so it was not acting as a barrier for a refill. And that was good news for us. I know we are out of time.
Thank you. Yeah, thank you, Dr. Maybe one or two last questions. There is a question here from Sylvester that asks, currently, what is the percentage in Kenya of children on ART who've not achieved viral suppression? I know you had this on your slides, maybe you can clarify. And then there is someone asking about you is equals to you. Perhaps you can just say a word. Yeah, so I know in the interest of time, maybe we can answer those two last questions, Dr. And then we can end the session.
Yeah, thank you so much. So U equal to U, undetectable viral load, undetectable, the definition for Kenya in the guidelines is less than 50 copies. In many other guidelines, it could be about 400 copies per mil. Undetectable viral load is equal to untransmittable virus. You cannot transmit it sexually to a partner. So yes, so that is the definition of U equal to U. Sylvester, I forgot the question by Sylvester. Challenges, what are so the percentage is about 35 to 45%. Western Kenya has better suppression than many of the low HIV prevalence regions. So you're going to meet that there's that duality we're having, but it's about 35 to 45% non-suppressed. And we're talking about their 1,000 copies per mil.
Thank you very much, Dr. Mugo. I want to appreciate you for the very good presentation. I know that we'll be getting a link to some of these presentations. Agnes and your team, you can give this to participants. They are asking for the same. But just to appreciate everybody for participating in this webinar. My name is Dr. Karo Ngunu. I'm the Deputy Director, Preventive Promotive Health at NMS. And we are really grateful for the work that we are doing through the PIMA study and the information that will assist us as we develop policy. So I want to wish everybody a good afternoon and thank you very much for logging in. Kwaherini.
Thank you.
Yeah, thank you very much, everyone. We'll be showing the upcoming sessions and you're welcome to join in. Have a lovely afternoon. Thank you very much.